Hey guys, welcome back to my channel. My name's Jessica Ward King, also known as the StigmaCrusher. And here in this channel, we deal with issues of mental health and mental illness from my twin perspectives as a person with lived experience of bipolar 2 disorder, as well as a person with a PhD in experimental psychology. If that sounds like your jam, you are in the right place. Go ahead and hit that subscribe button, and if you want to be notified every week when I post new content, hit that notifications bell as well. Well, with that, I guess it is time to start stigma crushing for another week. All right, guys, so this week is part 2 of our video looking at bipolar disorders in general. Last week, we looked at bipolar 1 disorder and specifically mania, as that is all that is necessary and sufficient in order to have a diagnosis of bipolar 1 disorder. This week, we are going to have a look at bipolar 2 with a focus on major depressive episode and hypomania, which are both necessary and sufficient to have a diagnosis of bipolar 2. So let's get right into it. To begin with, looking at bipolar 2, we're going to look at major depressive episodes. In order to be major depressive episodes, I should preface with, that's what major depressive disorder is composed of, is at least one major depressive episode. And it is the same episodes that we're talking about with bipolar as well. So it's not like there's a special bipolar depression. Although people sometimes do have different kind of ways of experiencing their diagnosis based on their symptoms, based on their diagnosis and that kind of thing. But the major depressive episode that we're talking about is one and the same that you would find with, the major depressive episode, unipolar depression. And what that looks like is that you have to have the symptoms for 2 weeks, most of the day, almost every day. And you have to have one of these 2 following symptoms. So one of them is depressed mood, which fairly obvious, right? And that is, a subjective experience of feeling sad, of feeling worthless, of feeling hopeless, that kind of thing. The other one you could have, though, is anhedonia, which just means lack of pleasure in life, in things that you would normally take pleasure in. There's just no pleasure in really anything for you if anhedonia is one of your symptoms. Now, of course, you can have both of these symptoms, but you must have at least one of these in order for a diagnosis of, major depressive episode to be given. So basically, they are the things that make the diagnosis most substantively. Then there are a whole host of symptoms that can go along with it. And so some of them are kind of body-related symptoms. So, insofar as mental illness, all mental illness is body-related. But what I'm talking about here is that you feel them in the body, you experience them in a very bodily, physical way. There are also the mood-based kinds of symptoms. And then there's also the cognitive or the thinking-based kinds of symptoms. So we'll look at all 3 kinds, but it's really interesting to note that major depressive episodes are not but they are not just feeling low or sad. There are a variety of things that go into it. And so let's start ourselves off with those bodily symptoms. These body symptoms are kind of funny in that they can go one of 2 ways. So we're talking here about sleep, we're talking about eating, and we're talking about moving around or being active. And you can either have too much, so too much fatigue, too much sleepiness, too much eating, too much hunger. Or you can have too little, so a lack of sleep, a lack of eating, a lack of moving around and being active. You can have either or. You can actually have either or in kind of like a piecemeal kind of system where you've got too much of one and too little of another, but quite often they do tend to hang together if you're having too much or too little. So, for example, my experience of major depressive episodes as part of my bipolar, I unfortunately I get the too much. So I eat too much, I gain weight, I sleep too much, I don't do anything, I don't get out, I don't do exercise, and all of which can, be very damaging for my body, for my health, all that kind of stuff. It's also extremely damaging. So, you may have seen me kind of go, unfortunately, but I catch myself. It is no better to be losing weight, to be not eating enough, to be moving, perhaps having, maybe too much energy, and not knowing what to do with it. So neither of those groups of symptoms are particularly pleasant, nor are they particularly adaptive to life. And that's, of course, why they're part of a mental illness, where you have this upset in functioning. So the way that you function in the world is damaged, and can cause damage in your life as well. We wouldn't diagnose it if it wasn't clinically significant distress, which is what the DSM will always say. In terms of those mood type symptoms, so you get the feelings of guilt, feelings of worthlessness, feelings like you're always the problem, you're always the one that's caused all the ills in the world, and those going along with the depressed mood and going along with the anhedonia cause a state of being where your mood and kind of, I like to call it my soul. They're my soul symptoms, that those things start to become a problem. In terms of the other groups of symptoms, which are the cognitive symptoms, you see a lack of concentration. So folks with major depressive episodes will tend to not be able to focus on their work, on school, on even their hobbies, not being able to continue to crochet, for example, or do model airplanes, or any of those kinds of things that require some kind of some level of concentration. The concentration's just not there. Distractibility is a feature, and so folks can really very literally be trying to focus on something, and something else happens, and all of a sudden they're over to the next thing, and so on, which really cuts into being able to do anything that you are wanting to focus on. There's also trouble with making decisions for people with major depressive episodes. So it's very difficult, not only to focus on the problem and weigh the pros and cons and those kind of things, but also just to make the decision to move forward, to take that risk. In some cases, the risk seems like a problem, but in other ways, it's really just that being able to focus on the issue and make a decision that makes sense for you and move on. You also have in depression sometimes, though not always, and it's not always a severity issue either. You have you have the symptom of thoughts of self-harm or thoughts of suicide, and so they can occur kind of at any, I just say severity, any level of depression, and they themselves can have a severity level from having thoughts that are passing to having a plan to die by suicide. So it kind of has its own gamut. Of course, this is the DSM we're talking about, so they want to make sure we know that this episode that we're having, that's of 2 weeks in nature, nearly every day, nearly the entire time, talking about, remember, anhedonia, depressed mood, and then all these symptoms, is not caused by something else. And with depression, that's actually a really important criterion, because there are a lot of things that end up looking like depression. And as you can see, it's really a laundry list of symptoms that, as we mentioned, goes from the mood to the soul, to the cognitive, to the physical. And so having kind of a group of these symptoms clustered together doesn't necessarily mean depression. It could mean, for example, low thyroid. If there's an increase in calcium in your body, that can have some kind of reaction that looks in a lot of ways like depression. Low vitamin D. We've seen people with seasonal affective disorder that have depressive episodes that are caused by, well, they're not caused by the light, but that are precipitated by that light. Diabetes can, in a lot of ways, heart disease can look a lot like depression. And so if it's one of those things, then it's not the psychiatric major depression. It doesn't mean that the symptoms aren't there, and it doesn't mean that the person's experience is any less valid. But it does mean that we're not looking at a psychiatric evaluation at that point. We're looking at a different medical viewpoint. I should actually notice too that grief can look a lot like a depressive episode. That is actually allowed for in the DSM. So normal grief, and normal here is based on culture, is based on the person themselves, is based on the circumstances surrounding, their grief. But normal grief is not considered a psychiatric symptom that is covered by the DSM. However, grief can become so severe or can go on for so long, kind of past what the normal. I mean, that's difficult. That's why a clinician that's very experienced needs to be making these decisions. But once you get kind of grief that's past the normal duration or the normal severity, then it kind of tips into, okay, now we're talking depression. Now we're talking the treatments that go along with that. We're talking the talk treatment. We're talking the medication route. We're talking all those things. So that is allowed for in the DSM, that period of grief, but also recognizes, much like postpartum mood states, that okay, at a certain point, it's normal to have some of these experiences, but then at a certain point it's no longer, and we need to start treating it. So that's where that line is. Hypomania is the other part of this diagnosis. And so hypomania, it really means lesser mania, or, less severe, less marked mania. And that's exactly what it is. I won't go too deeply into the diagnostic criteria because they are the same as for mania, with an important distinction. So I'll just remind you, so hypomania, just like mania, has to last for at least 4 days. The symptoms need to be present most of the day, almost every day. And you have to have an increase in mood or expansiveness or irritability. So this increase in energy, increase in mood in quite a lot of cases, as well as I mentioned, that increase of energy. So I just duped myself. So increase in energy as well as an increase in mood. And that increase in mood can either be a happy, expansive, grandiose kind of mood, or it can be an irritable kind of mood. Both are allowed. After that, it's the same criteria. You've got to have 3 or more of the following symptoms. 4 if your mood is only irritable. So remembering that heightened self-esteem or a sense of grandiosity, a decreased need for sleep, being too talkative or having that pressure to keep talking, a flight of ideas. And so like a manic episode, it's got all of these features. The difference is, instead of it being sufficiently severe to cause marked impairment in life, which mania is, mania often results in hospitalization due to its severity, hypomania doesn't. And so this is why a lot of folks with bipolar 2 disorder will present with a depressive episode, because the hypomanic episode isn't bad enough to take a person to the doctor. And it doesn't last as long as the depression either. So kind of if you're trying to wait it out, you may end up waiting out a hypomanic episode. But it is definitely not as severe and doesn't cause a marked impairment in life. And so quite often what will happen is a person may have hypomanic episodes along with their depressive episodes. and they go and they get evaluated for a depressive episode, and it is declared that they have major depression, so unipolar depression. And then as they're being treated, it becomes clear that they switch into a hypomanic episode. And then the clinicians go, oh, okay, we maybe aren't looking at unipolar depression here. Maybe we're looking at bipolar 2. And so the diagnosis of bipolar tends to evolve over time. So if you show up with depression, you get diagnosed with depression, then you show up with a hypomanic episode, you get diagnosed as bipolar 2, then you have a full manic episode, you become diagnosed with bipolar 1. And it's not like your disease has actually changed. It's just that its presentation has changed, and now we have more information. Now we understand more about what is going on in your body. It was always going on in your body, but now we understand more what was going on, and we have more symptoms to work with so that we can see what's happening. And I mean, it can even evolve further from there to a schizoaffective disorder or something like that. So really, psychiatric diagnoses, because they're based on a constellation of symptoms, as circumstances change, life changes, your body changes, your status in life changes, you can get different symptoms. And so it's not like it was never there, but we now have a better understanding. And so we do say that it has to be observable by others, these symptoms, but it's so, when your clinician is looking at you, they're like, oh, I see, you're talking really, really fast and too much and feel like you have to talk and you're really irritable. Oh, I see it now. I can actually see your symptoms. And so that's the one part. Another part is there should be no psychotic symptoms. So once you've got psychotic symptoms, those are symptoms like hallucinations and delusions. Once you've got those, then you get categorized up into bipolar 1 because those symptoms tend to lead to a more severe outcome. I myself actually experience psychotic symptoms, and they're likely a feature of my depression more, or my mixed states more than the hypomania. But I have a very mild experience where, for example, I can hear voices behind me. I know that they are not there, so there's no delusion, there's no belief that there are people talking about me, but I can still hear them. So you can have really kind of light, again, talking about severity of symptoms is difficult, but you can have symptoms that don't cause marked impairment, that are psychotic symptoms. But generally speaking, if you're experiencing those psychotic symptoms during a hypomanic episode, it's a manic episode. Why does it matter? Why should it matter if there's a mild symptom here or a mild symptom there? And it's just because of the way that we look at treating the disorder, the way that we look at classifying it in terms of, whether you're needing disability or things like that, but also the way we treat it. So how aggressively do we need to go at this? We have some indications that, if there's psychotic symptoms, it's likely to get worse faster, kind of thing. So that's why it matters so much what you classify something as. The book doesn't make the illness. The book doesn't make what your biology is doing, what your brain is doing, what your hormones are doing. But the book helps us predict how well our treatments are going to work and what kind of treatments that we are wanting to pursue. Finally, it's, as always, not attributable to another cause. So it's not, the hypomania is not attributable to a medication, for example, or another illness. So that's what major depressive episodes and hypomanic episodes look like. In terms of how are they experienced, so folks can experience, particularly with bipolar 2 disorder, quite deep and long-lasting depressive episodes. And these are just tendencies that I'm describing, but they tend to describe more long-lasting and deeper episodes. Hypomanic episodes tend to be shorter. There are things that can trigger a hypomanic episode. For example, taking a new antidepressant can definitely trigger a hypomanic episode. It doesn't always, but it can. Having certain illicit drugs can trigger it. So, things like speed that increase the way your body, that kind of get you in that state, it can trigger hypomanic episodes. So there are some things that can trigger you into them. And they tend to be shorter, much shorter than the depressive episodes. And this does tend to be cyclical. So you'll be in a depressive episode and then oftentimes go, switch, that's what they call it, switch over into a hypomanic state. And then, you may switch right back down into a depressive episode. You may recover and then repeat the entire experience. So it can be all over the place, which is what makes this disorder so difficult to treat and so difficult to live through, because it can seem like a hot mess for sure. I wanted to talk about another cluster of symptoms or I guess experience of symptoms that it also seems like a hot mess. And that is the mixed state. So quite often we have depression, which has lower energy as well as lower mood state. And then we have hypomania, which has higher energy as well as a higher mood state. But sometimes they get mixed up. And I mentioned irritability as one of the symptoms of hypomania, where it's a heightened energy situation, but not altogether a heightened mood as we would normally think of it. I mean, irritability is not a great time. But what you end up with when you're kind of going between depression and hypomania, you can sometimes get things a little bit stuck. And so you get that lower mood. And we've talked about as well with depression that sometimes it can be anger, sometimes it can be irritability. So you get that lower mood, but you get the higher energy. And now all of a sudden you're super irritable. You're active about it, but you're not happy about it. So that's one feature of a mixed state. And one of the big problems with mixed states is that you're feeling, for example, you're feeling very low, despairing, hopeless, but you have the energy to move and do things. And you can actually end up with energy to act on the feelings that you are having as a result of the depression. And so it can be a very dangerous state in terms of suicide or self-harm. Another kind of feature of a mixed state that could happen, the person could be exhibiting one kind of mood state and describing another. So they may be wailing uncontrollably, crying, but saying that they feel great. They've never felt better in their life. So it's a very confusing kind of state. And it seems to indicate a more chronic course, a more difficult course, and difficult to treat this kind of state. And it's very, very damaging and confusing for the person that's experiencing it too. Now, in terms of, we haven't really talked much about treatments. As I mentioned, things like antidepressants can cause a hypomanic state to occur. And in fact, that's one of the things that the DSM looks for and says, well, if it's just caused by changing the antidepressant, maybe it's not actually bipolar disorder. But the kind of treatments that you go for in bipolar disorder are usually things that are mood stabilizers. So not that they're intended to raise a mood or lower a mood, but they're rather intended to stabilize the mood. And so that would be things like lithium or like Depakote or even lamotrigine. So those are the kinds of medications that you look at for this stabilizing of the two mood states. Quite often, other medications are used. I am no clinician. Other medications are often used. Antidepressants can be in there sometimes. Things that help with anxiety. All kinds of things go into it. But just to give you an idea of the specificity of those medications. So that's bipolar 2 disorder. Things I want to note is that focus on the differences in energy versus differences of mood, and how those two things they're different. They're very, very different. So as I mentioned with the mixed state, you can have one, a higher mood and a lower energy, or vice versa. So energy as well as mood as two different things in this whole puzzle of what bipolar disorder looks like. And I also want to make clear that with bipolar 1, you can very often have depressive episode as part of bipolar 1. Quite often, hypomania is in there. Sometimes, going between a depressive episode up to a full manic episode, you end up with hypomania kind of somewhere in the middle. Not always. Sometimes they just switch right over. But quite often, bipolar 1 also features these two constellations of symptoms. So bipolar 1 and bipolar 2 disorder. Next week, we are going to look at cyclothymia, as well as the way that, and I've been teasing it out as we go, the way that we can conceive of the bipolar group of disorders in terms of, as I said, mood, energy, and teaser again, time. So that's us for this week. And do hang in there. You never know. Something may happen in the world, and I may post in between. If you hit that notifications bell, you will be notified every single time I post, so you won't miss a thing. Also, if you liked this video, give it a thumbs up. I am always looking to hear your comments, questions that you might have, ideas that you might want to see in future videos, and I will always be checking those comments and answering you. So please do engage with me in that way. I'd love to have you. And so that is us for this week. We are done stigma crushing for now. Have a great week, and I'll see you next time. Bye. Stigma Crusher.